As Laura kindly alluded to, what I'm going to talk to you today is about vertebral fracture identification, specifically in children. I'll move my slides on. We tested this and it worked. Now it's not working. Okay. I've moved on to the next slide now.
Looks good, thank you.
Brilliant. So vertebral fractures without high energy injury, such as in a road traffic accident, are highly indicative of a bone fragility. And they're not uncommon in children with chronic diseases, and they can be asymptomatic. So it might be that the child doesn't know about it, but it might be that the symptoms are not actually being picked up as a vertebral fracture. In some work by the Canadian group from Professor Ward, Leanne Ward and colleagues, they looked at some children. They did a natural history study of children taking glucocorticosteroids, and they found that 7% of children with rheumatic conditions had vertebral fractures before or within 30 days of starting those steroids. And in another group of children within the same study, those with acute lymphoblastic leukemia, 16% of those with newly diagnosed children had vertebral fractures. And most commonly, these fractures were seen in the thoracic region. So children do present with vertebral fractures. What do we need to think about when we want to try and identify a vertebral fracture? We need to think about which imaging modality we're going to use, how we're going to analyze that image, and how we're actually going to define something as a fracture. And I'll go through each of these things today, this afternoon. So originally, when you wanted to diagnose a fracture, you would have had a plain lateral radiograph. But with the newer and higher resolution bone densitometers, it's possible to do what's called a vertebral fracture assessment. So using very similar technology and to get an image of the whole spine. Now, this has been used for many, many years in adults, but it's only probably within the last decade that it's been used routinely in children. And we had to validate this study, this technology, to see whether it was actually useful in children against the gold standard of lateral radiography. So in Birmingham, in the centre where I work, we did a validation study where we took 80 children, and on the same day they had X-ray done by plain radiograph, and they also had DEXA lateral imaging done. And what you can see here, we're looking, hopefully you can see my mouse. So here are the lateral X-rays, and this is the DEXA image. And again, the X-rays versus the DEXA image. And in the graphs in the middle, we can see with the dark purple, that's standard radiographs, and the light purple is the DEXA image. And we can see that the greater number of valuable vertebrae were apparent in the VFA scan. And if we look at the distribution of where those unevaluable vertebrae are, we can see that it's in the thoracic region, the region where the study, the work from Canada, identified the most vertebral fractures. And this distribution of vertebral fractures is similar both with children, shown here with the dotted line, and with adults. It shifts slightly, and that's believed to be related to the biomechanics of the spine and the changing lordosis and scoliosis of the spine. But we can see that the greatest propensity to fracture is in this thoracic region. So it's the region that we really need to be seeing most clearly. But on the radiograph is actually we're least able to visualize. So going back to our validation study, what we looked at was we compared radiograph with radiograph analysis, VFA with VFA, and then morphometry, which is where we measure the shape of the vertebrae against itself, and then compared each of the technologies. And shown here by the red arrow, this is the vertebral fracture assessment by DEXA scanning, and we could see that had the greatest agreement. But it was only a moderate agreement between it. This is between different operators, 5 different operators. We got slightly less agreement for radiographs and from the quantitative techniques, and much poorer agreement when we compared the morphometric techniques with the radiographic or the DEXA techniques. One of the reasons we get such great disagreement is because of the identification of mild fractures. So looking at the image here on the left-hand side, we can see that with the 5 raters, how they identified or didn't identify deformities. So rater 1 and rater 2, you didn't see any deformities. Rater 3 felt that there were some mild deformities in T8 and T7. Rater 4 saw a mild deformity in T5, and rater 5 a mild deformity in L3. And this is not uncommon when we're trying to look at mild deformities. When we look at moderate deformities, there's much greater agreement, but it might be that there's less agreement whether it's a moderate or mild, and that's trying to work out how much deformation has actually occurred. If we look at the one on the far right, of course, everybody agreed here that these are severe vertebral fractures, but where there wasn't agreement was actually on the position. And when you're trying to do these diagnostic tests on a radiograph, very often it's hard to say to identify the vertebra. Well, whereas with the VFA scan, because you look at the whole vertebrae, it's much easier to diagnose where that vertebral fracture is. Of course, it may be less important where the vertebrae is, but compared to what degree of vertebral fracture you're seeing. But these are the areas where we get disagreement. If we then separate out these into 2 categories, so those with either no deformity or less than 25% height loss, so a mild deformity, versus those with a moderate and severe deformity, so greater than 25%, we can see that the agreement improves significantly. So this is the same, these are the same comparisons, and we can see that between all of the techniques, so between radiographs, vertebral fracture analysis, and quantitative techniques, that the agreement has gone from 40 to 65% up to 85 to 9%, so almost 100% agreement when we categorize those between the mild and non and mild and moderate and severe. Further work looking at this technique was in dose reduction. So here we used a pediatric phantom and a adolescent phantom to measure the radiation dose to the child and the young adult. And we can see that the radiation dose sparing for the 4-year-old child was 1.5 times, and for the 15-year-old child was 7 times. So it's not an inconsiderate dose sparing when using this VFA technology. So to bring all of that together, we can see that the advantage of using vertebral fracture assessment via DEXA is a lower radiation dose. We can see the whole spine in the image, so we can identify clearly where that vertebral fracture has occurred. We have improved visualization in the thoracic region with no magnification, and we have good identification of severe and moderate fractures. It's available at point of care, and that's very important if we want to be able to identify and act on these vertebral fractures. And it's important to know that it's at least as good as lateral radiographs. Because of this improved visualization, it's not better than, but it is at least as good, or you could say it's at least as bad when looking at mild vertebral fractures. But the important thing is it cannot be substituted for general spine assessment. So if you're looking for something other than vertebral fractures, then it might be that you need to use a standard radiograph or alternative imaging techniques. The other thing to bear in mind is that not all DEXA scanners produce the same image. So here on the far left-hand side, we have an older scanner. This is a GE Prodigy. The images I showed you before were from a GE DEXA. This is from an old Hologic scanner, the Hologic Discovery. And I'm sure you can appreciate the visualization of the spine on both of those is quite challenging. This is the newer Hologic machine, so perhaps more comparable to the IDEX images that I showed you. But even then, it can be quite challenging. And one of the reasons for this is because they use a single energy technique to acquire their image, which is very similar to that's used for the radiograph. However, you do have the ability to zoom in and use the dual energy facility functionality to get a better look at vertebrae if you're querying fractures. Alternative techniques might be the EOS scanner. We don't have one at our centre, but several centres in the UK do have them. They're very useful for screening for scoliosis, but they can be used to look for vertebral fracture identification. The advantage of this is it's done in the patient is either standing, can be done with sitting, so you're looking at a loaded spine. That might change the images that you see. And again, it's a low radiation dose, but it's quite an expensive machine and it's quite bulky. And then alternative technologies, so cross-sectional imaging. Cross-sectional imaging has the advantage that you can reformat the spine in various different planes, and that might help identify, especially in children with a significant scoliosis. MRI being the ionizing radiation-free technique, so obviously more desirable for children, but certainly in the UK, quite hard to get in non-emergent situations. And then you've got the CT scan, which is marvelous for looking at skeletal deformities, but sadly does offer the child a significant radiation dose. So it's not something that we would routinely do, and certainly not for screening for vertebral fractures. So moving on then, really, why are vertebral fractures important? Coming out of the International Society of Clinical Densitometry position statement from 2013, they made a statement on the definition of osteoporosis. And one of the most significant findings within that, or parts of that definition, is highlighted here in bold. And that's the finding of one or more vertebral compression fractures is indicative of osteoporosis in the absence of local disease or high energy trauma. And in children and adolescents, measuring BMD adds to the overall assessment of bone health, but it's not necessary as part of the assessment. So you can diagnose a child of having osteoporosis on the finding of vertebral compression fractures. So it needs to be part of their the diagnostic pathway for these children when trying to identify and define osteoporosis. So how do we diagnose a fracture? Well, if it's a long bone fracture, hopefully everybody in the audience could agree that's pretty straightforward. I don't think anybody would disagree that that's a vertebral fracture. But if I put the picture up on the right, I would challenge you to try and identify whether there's a vertebral fracture there and how you made that decision that it was a vertebral fracture. How we do diagnose vertebral fractures from radiographs and from vertebral fracture assessment. We use an expert pediatric musculoskeletal radiologist. There are several techniques we can use. We can use a qualitative technique, a quantitative technique, a semi-quantitative, quantitative technique. We can use automated techniques. And really, we need to know what's healthy normal variation. So for all of these techniques, whether we're using the expert or the quantitative techniques, or automative techniques, what we really need to know is what's normal for growth. For example, what's normal physiological wedging. All of these things are important when trying to diagnose a fracture. One of the biggest problems that we have is that there isn't a great deal of knowledge on what normal healthy variation of the vertebral growth looks like in the child. So moving on to the assessment technique. So first of all, the qualitative techniques. For this, we look at the end plates, we look at the whole vertebral body, perhaps look at the spine alignment and other non-spine clues. Versus the quantitative techniques, where we look at each spinal level, we look at the shape of the vertebral body and try and quantify that in some way. And there have been many different ways that we have to quantify the vertebral body shape, such as Ginant vertebral body scoring or the ABQ method. And I'll go through a few of these in the next few slides. So the qualitative reporting, well, we've briefly looked at that and seeing how that's absolutely fine for looking at moderate and severe vertebral fractures. But when we're trying to identify mild vertebral fractures, there's a great deal of disagreement. And there's disagreement between radiologists, and there can be disagreement between one radiologist when they look at one image on one day and when they look at it another day. And the problem is it's very difficult to see these subtle changes. Does this improve when we use quantitative reporting? Well, this is reporting that's available with the DEXA software. We have the ability to put 6 points on the image shown here. So you measure the posterior height, the anterior height, and the mid height, and you can use thresholds to decide whether something is a fracture or not a fracture. And this might seem appealing, except where you put the 6 points is actually quite subjective. And you can get differences, quite significant differences, depending on where you put them. So this is actually the same vertebra that you're looking at. And here we can see the points of the anterior vertebral body have been marked, and they appear to be in the right position. And if we look at the ratio between posterior and anterior height, we can see that there's been a 14% height loss. Now, with some definitions, that would be considered normal. However, if we move these points just very slightly, so making a very slightly shorter anterior height, we can see that height reduction is now 25%, and that's what we would call a significant osteoporotic fracture. And that's really just depending on where these points are. And the problem is, because it's a ratio, when you change one number, it can have a greater effect on the other number. What about semi-quantitative techniques? Well, I'm sure most of you are familiar with the semi-quantitative techniques by Harry-Junant and et al. And that here we use a combination of looking at the shape of the vertebrae. So we're looking at wedging, we're looking at biconcavities, or looking at crush, and then we define the degree of that deformity by how much height is being lost. So you can look at the image and measure the height on the ones that where you think there may be a deformity. And he had identifies 3 grades: mild, moderate, and severe. And this has been widely adopted certainly throughout adults and much so with children as well. I mean, in our centre, in our study, we did a slightly modified Junant scoring based on less than a 10% height reduction being normal, between 10 and 25% being a mild reduction, a mild vertebral fracture, 25 to 50 being a moderate, and greater than 50 being a severe vertebral fracture. And these levels were chosen by our expert paediatric radiologists on the basis that it's very difficult to see a difference between 20 and 25%. And there's some work from some CT scans that have been reconstructed in the sagittal plane that have said anything with a deformity of greater than 10% is unlikely to be normal. So that's the rationale behind the thresholds that we use. Moving on to the algorithm-based qualitative diagnosis. So this is using looking at the shape of the spine, looking at the end plates of the spine, defining whether one or both end plates are abnormal, looking at the degree of height reduction, whether that's greater than 25%, less than 25%, and then commenting on non-osteoporotic deformities or the inability to identify. On the left here, we can see the technique that's used in adults, and it's quite complex. It's been simplified to use in children. And I'll just show you an example of that. So this is from work from Sheffield, where they looked, again, they were comparing DEXA images with radiography images. And here they're looking at L2, and they identify that it is a less than a 24% deformity, and it's only affecting a single end plate. So if we look at the advantages versus disadvantage of these semi-quantitative techniques, the advantages are it's quite quick. It's been widely used in clinical trials, mainly in adult studies. It's used by the International Osteoporosis Foundation and recommended by the ISCD. And as an advantage, it's available on the bone densitometers. The disadvantage is it's still subjective. The vertebral deformity has to be greater than 20% for it to be identified as a fracture. Differential diagnoses are very difficult, so trying to diagnose between osteoporotic, traumatic, or non-fractured deformities. And it's also available on the machine. And this can be a disadvantage because it may be used or misused without sufficient training. However, from the validation studies, there have been several now. This is ours in Birmingham, but there's Sheffield in Glasgow and the Italian group. There's been many validation studies. So I think we're happy to use VFA in children and happy to use the semi-quantitative techniques. What about the automated morphometric techniques? Here we can see an example of a 6-point automated program. So this is almost mimicking what happens on the bone density scanner, or a more sophisticated 33-point technique, where this uses machine learning algorithms, so an AI type approach to look at vertebral body shapes and to identify fractures. And the group in Sheffield did some work trying to validate this, we can see here they took 420 images from VFA scans, and they used an expert radiologist to score all of the DEXA scans. They also used the 33-point and the 6-point automated techniques. And overall, so looking for any fracture, the sensitivity and specificity was quite high, with a 10% false positive and a 20% false negative fracture rate. So this is identifying something as a fracture when it isn't a fracture. And if that was separated out into those to mild fractures identified by the 33-point analysis and by the 6-point analysis, we can see that the 33-point analysis is slightly better than the 6-point analysis, but it's still pretty poor identifying those mild vertebral fractures. So whether we use an expert pediatric radiologist, whether we use automated techniques or semi-automated techniques, is that identifying those mild vertebral fractures is still very challenging. But is it important? Does it matter for the mild vertebral fractures? Obviously, the moderate and severe vertebral fractures is a significant deformity. We know we need to do something about it. But do we need to do anything with the mild changes that we see? So looking at some mild changes, here we can see a vertebrae with the 15% height loss, and here's somebody with a 26% height loss. So this might be somebody who then goes on to treatment, whereas this might be somebody who that we just monitor over time. But I just want to highlight the importance for screening. This is some work from the Canadian group again, where they identified children through from screening, and they looked when they started their glucocorticoid steroids, and you can see some mild changes that developed over time into mild fractures, versus those that actually presented with back pain who already had significant vertebral fractures. And we can see grade 2 fractures in the thoracic and the lumbar spine. So trying to identify them when they're asymptomatic and stop them progressing is obviously ideal. To be able to identify those mild fractures, it might be that we use longitudinal studies, so we can monitor children over time, and that can help us identify those changes from where they start from and how the shape of their body changes. We can see here, nice normal healthy vertebrae, still normal, some very subtle changes, and now vertebral fracture. So it might be that these subtle changes, so this mild fracture here, that might not be picked up very easily, is actually the indication. If we look at the vertebrae above it and actually below it, those changes are seen in all 3 vertebrae. Here's another example. So here we can see normal shaped vertebrae, still normal, subtle changes to the end plate, severe vertebral fractures. So the mild changes are important because they very often lead to these more severe painful and debilitating vertebral fractures. So identifying mild vertebral fractures is definitely something we need to try and improve. Another reason for trying to identify fractures early is trying to know when we can best intervene and improve the outcome of these vertebral fractures. And this is some work looking at 60 children with OI. They had VFA scans done at baseline and 1 and 2 years. Treated with bisphosphonate, and they were really looking at vertebral reshaping, and they saw in their study that there was significant improvement in vertebral shape on treatment. But this vertebral reshaping only occurs with growth. So if the spine is not growing, it's not possible to reshape. But by identifying a vertebral fracture early, treating it early, allowing it time to hopefully reshape if it's done sort of pre-puberty before growth is finished, means the child's got a much better outlook of having a normally shaped vertebra and a normally shaped spine. So what about non-fracture deformities? Well, we know that all fractures cause a deformity, but not all changes in the shape of the vertebrae are caused by vertebral fractures. If we look at the normal development of a healthy spine, we can see here it changes from the slightly ovoid shape. Over time, it becomes more cuboid, and this is just natural development. Versus physiological wedging, we can see here that this slight bulge in the posterior end, this is normal development. This is vertebral fracture, where you can see clear end plate diversion from parallel. So they've lost the parallelism between the adjacent vertebrae. Other non-fracture deformities, we see these through growth. Schmall's nose, sickle cell disease can cause these classic H-shaped vertebrae, or histiocytosis, where you get the vertebral planar. So we've done the work, we validated the technique, we're now using it. We know that there are problems with mild vertebral fracture identification, but the technique has now been adopted by the International Society of Clinical Densitometry. And in their most recent guidelines, the 2019 guidelines, they identified that DXA can be used as a substitute for spine radiography, the identification of both symptomatic and asymptomatic vertebral fractures. And that after they've had the VFA scan, additional imaging should be considered in some of these circumstances. So where the vertebrae are technically unavailable, as you can't see them, and where the detection of a vertebral fracture would actually change clinical management. So you only want to do further imaging if it is going to impact management. Where you've got a single mild vertebral fracture, and again, that the confirmation of that mild fracture would change clinical management. And then when the findings are not typical of an osteoporotic vertebral fracture, and as I said earlier, so VFA isn't a substitute for alternative imaging. When you're looking for other things such as destructive inflammatory or malignant processes, then you need to do further imaging. So what about acquiring these images? For a standard image, you need to acquire from the whole of L4 up to T4. They need to be lateral, so you can only see one single edge on the screen. You want to try and avoid the beam can effect. That's where you can just about see it here, where the vertebrae are rotated, because it makes it very difficult then to differentiate between a rotated vertebrae and a biconcavity. And you need to try and make sure that where there's evidence of any sort of scoliosis, if it's mild scoliosis, that there's sufficient padding to try and make sure that that spine is as parallel to the scanning couch as possible. There are some challenges, and these are not unique to children, but challenges that we see. So here we've got, and there's something going on, but actually the child moves. So it makes it very difficult to know whether the changes that we see are due to movement or real biological changes. This is an example of a child who's got a bit of a mild scoliosis, but actually we could improve the visualization of the spine by lying them. This is lying in the decupitous position on the left-hand side. So we turned them over and scan them on the right-hand side, and we can see that it's improved the visualization of the thoracic spine. In this example, the child has got such a severe scoliosis that no lateral imaging, whether it's by DEXA or via radiograph, is going to allow visualization of the vertebrae. And the only thing that can really be done here would be cross-sectional imaging. So just having a look to see how VFA has changed clinical practice. So this is in our centre. We did an audit going back to 2004, and these were X-rays requested after they'd had the DEXA scan. So they'd had the DEXA scan done, we'd identify low bone density, and then they were referred on to have an X-ray to look for vertebral fracture. And we can see that quite a large number of them went on to have X-rays. And then over time, with the introduction of VFA, so back in 2010, we can see how it's slowly been accepted into clinical practice. And from 2014 onwards, so for the last, well, nearly 9 years now, we've been predominantly using VFAs to look for vertebral fractures. One of the important things when using whatever type of imaging you're using when reporting vertebral fractures is how you report these, and this is a contentious issue both in adults and the adult and the pediatric field. It's important that when you look at the appearance of the vertebral body, that you identify it clearly and unambiguously. And we recommend using the following terms. So either identifying as a vertebral fracture, as a non-fracture deformity, or normal. And try and avoid using terms such as wedging or vertebral height loss or deformity or end plate depression. In some recent work, a survey was done from reports from lateral imaging, and what happens is when these terms are used, the referring clinician is still unsure of whether it's a fracture or not a fracture, and then whether they should be treating or not treating. If it's a fracture, use the word fracture. If you don't know, if it's equivocal, be prepared to say it's equivocal and you don't know what it is. Identify the images that you can look at. So if you can look at the whole spine, that's great. But if you can only look at part of the spine, make sure that that's been identified in the report. Always review any previous imaging, whether that's previous imaging of the same technology or different technology. You'll very often find, certainly in our centre, that if a child is coming for bone density assessment for acute lymphoblastic leukemia, they'll have had some sort of cross-sectional imaging done. So that can be useful in trying to look at the shape of the vertebrae. Highlight any technical problems that you might see, whether there's any scoliosis, any due to poor positioning, either because of the patient or because of the operator, any artifacts that might be there in the imaging. And most importantly, make sure the report is actionable. So what you say in the report can be actioned on, whether that's normal and nothing needs to happen, or whether there's a vertebral fracture and something needs to happen.